This is Dr. Stephen Rudolph from the Stroke Center at Maimonides. This is one of our series of videos on stroke for the ED. The Joint Commission, which designates our Stroke Center, has requirements for professionals in the ED. Specifically, they would like you to know about the administration of IV TPA to patients within 3 hours of onset. TPA, case selection, and the use of the medication will be dealt with in a separate video. This video will deal with identification of patients for acute stroke treatment. We'll speak about the stroke code, who qualifies, a little bit about how we deal with TIAs, the basics of acute imaging for the patient that arrives with an acute ischemic stroke, and the patient selection for the types of acute treatment that we have available. What we hope to learn is how to determine who qualifies for the available stroke therapies, what acute stroke therapies are available at Maimonides at the present time. The short answer is that we have every available stroke therapy at our disposal. We'll look at the diagnostic tests that are done in the ED, and we will focus on what happens in the first few minutes following the arrival of a stroke patient. So for acute stroke, we first deal with triage. It's knowing the signs and symptoms of stroke. It is sudden, sudden, sudden. The patient is in their baseline state, and they undergo an acute change. And so the suddens are sudden change in speech or understanding speech, sudden weakness of one side of the body, sudden persistent vertigo or loss of balance, sudden loss of vision in one or both eyes. We have included double vision on this slide because it is usually a sign of an acute neurological event, not necessarily a stroke, but we believe that it is something that should be paid attention to. Sudden numbness on one side of the body, especially if it involves the face, and sudden severe headache, which may be a sign of subarachnoid hemorrhage. Let's start with the stroke triage and calling the stroke code. And so when a patient arrives with this acute change, the first question is it a stroke? HMED, our clinical system, uses the FAST algorithm: face, arm, speech, time. Is there facial asymmetry? Is there difficulty with speech? Is there a drift of one arm when both arms are outstretched? The T in FAST is time. It was originally developed for the public to be able to recognize stroke. It was not developed as a triage tool for professionals in hospitals. And so when we say FAST plus common sense, we like to point out that it doesn't involve weakness of the leg, which may be predominant or exclusive. It does not involve numbness on one side of the body, or loss of balance, or loss of vision. So although the FAST algorithm is in our system, please know the signs and use common sense. Determining the time of onset is absolutely crucial to be able to determine what type of stroke therapies are available for that patient. And so the two types of determination are, first, the time the patient was last known in their usual state, the last they were observed, or the last the patient can tell you. At times there's an observed onset and the observer can tell us the exact time. But sometimes it's necessary to delve a little deeper, find the patient's phone, see who they spoke with last, try to find a relative. It's absolutely crucial to determine the time of onset. The last item on the slide are there any showstoppers? Are there any issues that absolutely limit the types of therapy available from the beginning? Is the patient on active anticoagulation? If they are, they can't get IV-TPA. Have they had recent surgery? That's an exclusion from IV-TPA. Have they ever had intracerebral hemorrhage? There are a few questions that could be asked that will narrow the options. We call a stroke code at Maimonides by dialing 33, and the stroke code is for symptoms within a 12-hour window. Why is it a 12-hour window? Number one, we're involved with clinical trials, and those clinical trials have 12-hour windows. We may treat patients with endovascular therapy up to 12 hours. And we are interested in dealing with patients that have TIAs. So the last bullet on this slide, if symptoms completely resolve, is it still a stroke code? The answer is yes. Who gets paid for a stroke code? Well, stroke neurology. There is always a PA or NP in hospital for the stroke team. The CT scan technician in the ED should be paid, and the attending that is covering interventional, and most likely the PA that's covering with them is also paid. So what happens from the moment the stroke code is called? The person who calls the stroke code should give the extension that they're sitting at, and somebody should be at that extension when the stroke team calls back to provide the basic information, findings, time of onset, whether the patient is on anticoagulation. The attending on the north side must be alerted immediately to the stroke code. A nurse should accompany the patient from triage to the recess area on the north side and do a live handoff to the nurse on the north side. The initial stabilization is to get vital signs and obtain bloods, not to do an EKG, not to do a chest x-ray. No time can be lost. It's vital signs, drawing bloods, and getting IV lines. We aim for an 18-gauge IV in one of the lines because that is required for CT angiography. The patient is then moved for the non-contrast CT scan, which should be ordered immediately. We do not give any antithrombotic agents. We do not give any other medications until the patient has the non-contrast CT. Because at this point, it is unknown whether the type of stroke is thrombotic or hemorrhagic, ischemic or hemorrhagic. It is not possible to clinically differentiate an ischemic stroke from an intracerebral hemorrhage. The non-contrast CT only takes less than 30 seconds to be done, and this provides important information. What can it show? It may show nothing, no evidence of acute stroke. That may be because it's too early for the CT to demonstrate changes. There may be an alternative diagnosis. It may show a well-developed acute stroke. A well-developed acute stroke may indicate that therapy is not available. It may indicate that the time of onset was longer than suspected. It may be necessary to go on to an MRI if the patient does not have a pacemaker or another contraindication to MRI. It may show early signs of stroke. And in our imaging video, which will follow and have detail, the early signs of stroke may be demonstrated: loss of the insular ribbon, flattening of sulci over the surface, or loss of the basal ganglia. This may also exclude the patient from further therapy if it's extensive. It may demonstrate a hyperdense vessel. You can see clots in the middle cerebral, in the basilar artery, in the internal carotid. When a hyperdense vessel is demonstrated, it very often means that if the patient has not sustained significant damage to that point, that they are candidates for endovascular therapy. Of course, the scan may immediately demonstrate hemorrhage. Hemorrhage is immediately demonstrable on CT. And so an intracerebral or subarachnoid or subdural hematoma may be demonstrated. At times, another type of lesion is demonstrated, such as a neoplasm. And so, when this information is obtained, decisions can be made regarding triage and therapy. Almost everyone gets a non-contrast CT. The exception may be pregnant women. If subarachnoid hemorrhage is demonstrated, the patient should stay on the table and have a CT angiogram to exclude an aneurysm. With intracerebral hemorrhage, the CT angiogram is usually not performed immediately. For ischemic stroke, a decision must be made. If a patient is eligible for TPA, they may be brought back and treated immediately. If it is suspected that this will be a case, that endovascular therapy will be necessary, the patient may stay on the table and have a CT angiogram immediately. It depends on where the patient is in the treatment window, how eligible they are, and whether endovascular therapy is considered. Here are the current time windows. IV TPA can be given to people of all ages in under 3 hours. That's the FDA-approved treatment for stroke. The FDA approval for TPA, alteplase, is only up to 3 hours. Patients who are excluded from TPA or are considered for endovascular therapy may have it at any time, and they may have it after IV TPA. TPA under 4.5 hours has some exclusions in terms of age below age 80, diabetics with prior stroke, and very severe strokes. Endovascular therapy by the current guidelines should be started by 6 hours following the onset of symptoms. And beyond 6 hours, there are cases that qualify. That is beyond the scope of the syllabus. So who is eligible for endovascular therapy? It may be a patient that has received IV TPA and has a lesion that's considered a target. These are usually very severe strokes. It may be a patient that cannot receive IV TPA immediately postoperatively on active anticoagulation, or that are in the extended time window. But the real target for endovascular therapy are those with a large occluded vessel determined by CT angiography. These are usually patients with the most severe strokes. Endovascular therapy is performed in the angiography suite on the 3rd floor. The devices that are used at the current time are retrievable stents that are placed via catheters into the cerebral circulation and used to perform thrombectomy and clot retrieval. The patients must have some selected characteristics according to current guidelines to benefit the most from endovascular therapy. They should be independent at baseline. There should be no significant demonstrated damage on CT at the time the procedure is started. They should have a large vessel occlusion that's demonstrated, and they should be able to be treated within 6 hours of onset. The reason we say large vessel occlusion is that the current generation of devices that are used can only be inserted into the size vessel that represents proximal intracerebral vessels, the early branches of the middle cerebral. And so distal branches at the current time are not reachable by endovascular devices. Just some hints about determining the patient's previous status. We do it by asking functional questions, not was the patient fine. You would ask, was this patient able to walk alone? Were they allowed to be outside their home? How were they eating? Were they eating independently? Did they have to be fed? Did they recognize family members? Did they recognize them by name? These are the type of questions which you will gain experience with and that will help you determine the patient's previous status. The last item we'd like to deal with are rapidly improving stroke signs. A patient comes in with a hemiplegia, they're put on a stretcher, they start to improve. Their weakness improves, maybe their language improves. And the thought may cross the mind of the providers, we don't need to treat this patient. Well, history has demonstrated that if people don't completely recover, that they may worsen, and that a high percentage of the patients who don't completely recover but have rapidly improving stroke signs will be disabled in the future. So unless a patient completely recovers with no deficit, treatment will generally be administered even if they have rapidly improving stroke signs. I hope you've learned something. Our other videos will cover accompanying topics. Thank you.